We're going to be talking about the newborn examination, and much of the newborn examination is similar to what you've already learned about other aspects of the examination, but there are certainly some unique features which we're going to talk about as we go along. As with any other examination, the first step before you touch the patient is to wash your hands, especially important in the newborn, where we worry in a immunologically naive patient about introducing infection. I've already washed my hands. I'm not going to show you that, but hopefully you all know how to wash your hands. If not, go back and review that video. Much of what we can learn about a newborn, we can actually learn just by inspection. And so that's always the first step with any pediatric patient, including a newborn. Oh, I'm sorry. There you go. There you go. There we go, good. So there's lesson number one, that infants like to suck, and that calms them down. So inspection includes a whole host of things that we're going to look at. The first is the general state of the baby. So is the baby asleep? Is the baby awake and quiet? Is the baby awake and crying? What is the general appearance? And obviously this is a baby who was a moment ago awake and screaming. You can actually take advantage of that and take a listen to the sound of the cry and hear that the cry was a strong, vigorous cry. It wasn't weak, it wasn't high-pitched, it wasn't hoarse. Those can all be indications of various kinds of infection or problems with an infant that you want to watch for. You can also look at the color of the infant. So normally babies are quite pink. Sometimes, especially in the first 24 hours or a little bit longer, you might notice a little bit of acrocyanosis, which is the bluish tinge to the hands and the feet as infants transition from adult circulation, from fetal circulation to newborn circulation, and that usually gets better with time. This infant is actually, this is Riley, by the way, and he's was born about 32 hours ago. So you notice another thing, which is he has a very slight jaundice, which is the yellow tinge that you might notice sort of at his face and upper chest. That's a normal finding in infants, and it's something we monitor to make sure it doesn't become too elevated, but the level of jaundice for Riley right now is normal for his age. Okay. You also want to evaluate tone, and the way you evaluate tone, okay, I'm sorry. The way you evaluate tone is by looking at his general position. If you notice, his arms are flexed and his legs are somewhat flexed, and that's what we like to see. If an infant has low tone, you might notice that his arms might be extended, his legs might be extended, and that would be a concern. So without even laying touch on the patient, you can actually evaluate the tone of a newborn patient. Then you want to look for signs of respiratory difficulty. This is an infant who's breathing very comfortably. You can, there you go, good job. You can evaluate respiratory difficulty in a number of ways. One, you notice at his chest, you might notice here some what are called retractions, which are indentations in the chest as the chest wall as the infant breathes, and those can be signs of respiratory difficulty. Infants' chests are very pliable, so when they work hard to breathe, the intercostal muscles actually pull the chest inward, and that can be a sign of distress. You also might look at the nose and notice what's called nasal flaring. And nasal flaring is basically widening the patency of the nostrils to increase air entry into the whole respiratory system, again, to improve air exchange. And Riley has no nasal flaring. And finally, you might hear a sound called grunting, which is basically an expiratory with each breath. And that has basically caused a response to the infant to essentially keep the alveoli open for a little bit longer at the end of the breath, another way to improve air exchange in infants with respiratory distress. So again, retractions, nasal flaring, and grunting all can be signs of respiratory difficulty. Okay. Take that. There you go. Okay. So one of the important lessons that you might have just noticed is that important part of the exam is actually sort of optimizing your steps depending on the patient. When the baby's quiet, you're better off examining the parts that you can examine when the baby's quiet and leave the parts that are more intervention for when the baby is not as quiet. So I'm going to try to get this baby quiet again in a second. A couple of things I'll mention in terms of inspection before we go ahead and touch the baby. Number one is sometimes there are signs that you might recognize of syndromes like Down syndrome or other kinds of genetic syndromes that are apparent on the infant. So any feature that looks unusual, you might want to take note of in terms of describing the baby before you examine the baby. The other thing you might want to look at is signs of the baby's gestational age. A couple that you can kind of look at are the number of folds on the feet there are a sign of gestational age. Some signs of mobility of the ear and of the shoulder and things like that. And there are two exams called the Ballard and Dubowitz exam, which are more than we're going to talk about in this session, but that you can use to assess gestational age if you're not sure about the gestational age by the dates of the mother's last menstrual period. Since he's quiet, I'm also going to point out some things on Riley's skin. He has a few little red macular lesions with sort of like white centers. It's called erythema toxicum. You notice a couple here. Erythema toxicum is a very common rash in newborns in the first few days of life. Toxicum is a misnomer. It's not toxic in any way. It's actually very normal for infants. And if you took one of those pustules and looked it under a gram stain, you'd see eosinophils. So no one really knows why it happens, but it's very, very common, and nothing needs to be done. It goes away in a few days of life. So any sort of birthmarks of that kind, you might want to point out in terms of your exam. He also has on his nose, you might have noticed before, little white bumps on his nose, and that's called milia. Again, a very common normal baby birthmark you might find that does resolve on its own within a little while. The next thing to talk about are measuring vital signs in a newborn. And for newborns, we consider growth measurements part of the vital signs. So that includes weight, it includes length, and it includes head circumference. Most often you're going to actually collect this data from the chart, and you're not going to measure it yourself because you're looking mainly at birth weight and birth length and birth head circumference. However, if you need to measure them, you should know how to do it accurately. When you measure head circumference, you're going to be essentially measuring the widest part of the diameter of the head, and that's essentially from the maximum part of the occiput in the back to the widest part of the glabella of the forehead in the front and the diameter around that. And the length should be measured with a good equipment, which would include a fixed plate to put the head against, and then a movable plate to measure the feet against, and that's how you're going to be able to get an accurate measurement. But as I said, most often for students as well as for physicians, you're going to be gathering this data from the chart. So when you're plotting a growth chart, one key is to make sure you have an accurate gestational age. Again, you'll get this from the chart, but again, for your information, you should know that the most accurate gestational age is by date of last menstrual period, if that's accessible, or if not, by an early ultrasound. So if we look at Riley, for instance, Riley's gestational age is 40 and 5/7 weeks, and getting his growth parameters from the chart, his weight was 4.515 kilos, his length was 54 centimeters, and his head circumference was 37 centimeters. So if we plot out his weight, you can see on the growth chart that he is well above the 90th percentile for his weight. So this would be classified as large for gestational age in terms of weight, and there are a variety of reasons to have that. The most common reason for large babies is actually large parents. So often it is not a concern, but it's something you certainly want to pay attention to. When we plot his length as well as his head circumference, you'll see that these, once again, fall outside the normal range. So he is symmetrically large. Okay, so one of the first things you might do after you inspect the infant is check the heart rate and respiratory rate. And as you've learned, the trick with the respiratory rate is that infants have periodic breathing. That means from second to second, the respiratory rate might be fast and then slow, and that's normal. So to get a true assessment of the respiratory rate, you really need to check over 1 minute. And you can do it essentially with a stopwatch and watching the movement of the chest in and out over 1 minute. And we can do that now. Okay. And then the heart rate, again, heart rate is more regular. The main thing you'll notice when you listen to the heart is that the rate is faster than it is in an adult or even in a younger child. A normal heart rate for a newborn is between 120 and 160 beats per minute, which makes it a bit of a challenge when you're listening for murmurs because you really have to be listening closely. So what I usually advise students to do is really separate out the different sounds. So listen to S1, listen to it for a while, then just switch and listen to S2, listen to that for a while, and then try to hear in between those two and hear if you see or hear any sounds, either in the systolic or diastolic portion, a murmur or a gallop. But again, this is not an easy exam. It takes lots of practice. So I'm going to take a listen to the baby now. And just like with an adult, you examine in 4 quadrants. You can palpate the point of maximal impulse first. And there I'm feeling his point of maximal impulse at this point right here. Okay, and I'm going to take a listen now. And while the infant is quiet, I'm also going to take a listen to his lungs and to his abdomen. Good. And all that sounds just fine. So examining the abdomen in an infant is just like examining in an adult. Preferentially want to have the legs flexed, which his are automatically. And you start with light palpation. I've already listened to his abdomen. Okay, I'm feeling along the left side now, feeling for a spleen. Now feeling along the right side. It's normal to have a slight palpation of the liver just below the costal margin in infants. That's not a worrisome sign. A centimeter or so in the midclavicular line would not be out of the range. We don't normally percuss the abdomen as part of the routine screening exam in newborns, but if you were concerned about something, the liver span, for instance, you could certainly do that. Okay. You might notice in this infant the umbilical cord. And if it weren't dried up, you might look for 3 vessels. But usually by the time we see the infants 24 to 48 hours later, it's dried up enough where you're not going to be able to see that. But right after birth, that's something you want to watch for. And that can be, the 3 vessels are 2 arteries and 1 vein. And if that's abnormal, that can be a sign of a problem with the placenta. So the other parts of the cardiac exam besides palpating the point of maximal impulse and listening to the heart, in 4 quadrants is examining the femoral pulses. The femoral pulses are weak, and that can be a sign of coarctation of the aorta or other narrowing that you might want to look into. I'm not going to do that now because I don't want to disturb the baby. His eyes are closed, so I'm going to kind of take advantage of the steps that I can, and I'm going to start at the head and examine the head. And with the head, what you basically want to look for is first on the skin any sign of bruising from a traumatic delivery, which Riley does not have. Then you want to feel for molding. She has a little bit of, that's just a little bit of soft tissue swelling that occurs during the course of patches through the vaginal tract. And then you want to examine the fontanelles. And Riley, like all babies, has 2 fontanelles, the anterior fontanelle, which is here, and then the posterior fontanelle, which is here. The posterior fontanelle usually goes away within a few weeks of birth, while the anterior fontanelle lasts, a year on average, and can be a little bit more, a little bit less. And then you examine the sutures of the skull. So you can examine the sagittal suture, you can examine the coronal sutures. And basically what you're looking for here is to make sure that the sutures are of normal size, they're not excessively wide, to make sure the fontanelles are open, that they're not fused, there's no ridging, which can be a sign of premature closure of the sutures. And you also want to examine the fontanelle for bulging, which can be a sign of inflammation of the underlying meninges in meningitis. That can be a sign which one usually doesn't see in the newborn, but certainly still worth looking at. In addition to molding, two other things you want to look for are caput succedaneum and cephalohematoma. Both of these are swellings you might notice in the occiput below the skin, above the skull. The difference between the two of them is that cephalohematoma is also below the periosteum, so it will be confined to suture lines, while caput succedaneum crosses suture lines. So now I'm going to do a little bit of the musculoskeletal exam. I'm going to examine the neck and the clavicles. The clavicles, sometimes during birth, you can have a clavicular fracture. So what you want to do is feel along the course of the clavicles on both sides and feel for any step off, bumps, things like that might indicate a clavicle fracture. And if there is a clavicle fracture, they actually heal very well. The neck, sometimes what you might see is what's called torticollis, or a twist to the neck, where the infant prefers to have the neck turn one way or the other. So I'm going to feel along the sternocleidomastoid here for any swelling, might indicate a hematoma. Over time, that can turn into fibrous tissue, which might lead to torticollis. Very, very rarely that can be from a problem with the cervical spine. And you can see his range of motion of his neck is quite normal. And then looking sort of at both sides of the neck, it looks pretty symmetric on both sides. Okay. Okay. Another thing to look at with the chest is you want to look for the placement of the nipples. If they're very wide spaced, then that can be a sign of some abnormalities as well. And then you want to palpate for breast buds, which are actually normal in infants, and Riley has some, and that's just a sign of maternal hormones, essentially. Okay, so that looks good. Yeah, Riley's eyes are open, so I might try to examine his eyes while I can. And you want to look, if you can, at the sclera and see if there's any hemorrhage. You also want to look at the red reflex and make sure it's symmetric and round. A sign of the red reflex is basically a way of looking to make sure that light is entering all the way through the into the retina and then coming back out as a reflex at you. And it can be anywhere from pale to bright red, depending on the infants. You also want to look for changes in the shape of the iris, which can sometimes be what's called a coloboma, where the iris has a defect in it. Again, if you can kind of get a close-up of Riley's eyes, everything looks symmetric, and his red reflex is symmetric as well. So we're examining now the infant's back, and you're looking along the spine. Make sure there are no tufts or dimples, any other abnormalities that might indicate an underlying problem in the spine, like spina bifida. And make sure you look at all the way down to the sacrum. So I'm kind of spreading out here, looking for a dimple. Again, for Riley, everything looks absolutely normal, so that's good. Okay. 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 And then in terms of the ears, the main goal really is to look at the outside of the ears, make sure that the shape is normal, the position is normal. One rule you can use is you want to trace a line from the eyes, a line going through the eyes, through the ears, and at least a portion of the ear should be above that line. Otherwise, you might have what's called low-set ears. And again, so I'm going to check both sides of his ears here. Okay. We've already done a fair amount of assessing his tone just by looking at him and seeing that he's in a flex position and watching his response to the exam, which is appropriate. a couple of other things you can do. You can look at the grasp reflex. It's normal for infants when you put something into their palm to grasp it, which he's actually already has his palm in has his thumb in his palm. So I'm just going to kind of open that up, and again, you can see him kind of grab at things. Actually, have the same reflex here. You can see him kind of flex his feet around your finger well, and that's a plantar grasp reflex. Okay. We've seen his suck reflex, and the other thing you might look for is a rooting reflex. And you get that basically just by touching against the side of the, let's put his head to the midline here. Just kind of, and then just kind of touching along the side here, and look for him to move his head towards the area. And the idea behind that rooting is, again, just there we go. You saw a little bit of it right there, that he's looking to feed. So if the nipple kind of brushes anywhere near his mouth, there's a reflex to kind of have him move his mouth in that direction. And there you go, and now he's sucking. So there's the root and the suck that I just examined. Okay, and then finally we have the Moro reflex. You saw a little bit of a spontaneous Moro, but one way you can elicit it is you basically want to sort of have him have a sudden drop in his head. So not to hurt him, I'm actually going to flex his hands. I'm going to lift him up a little bit, and then I'm going to drop in a second. You'll see him kind of startle. Watch. Whoop. There we go, and there's the Moro. I have my hand behind his head, so I'm making sure he's not dropping and hurting himself, but still there's enough of a drop in gravity to see. And the normal Moro has two components, which you just noticed, which one is the sort of extension out, and then the flexion back in, and it's symmetric. And if there was an asymmetry, that might indicate a brachial plexus injury or some other problem. Bless you. And sneezing is normal for infants. When you listen to the posterior lung, I'm just going to turn him a little bit so I can listen to his posterior lungs. Okay, so that side sounds clear, and now I'm going to listen on the right side. Okay. So by knowing your anatomy, you can find the femoral pulses fairly easily. You all know that it's a nerve, artery, and vein along the femoral sheath here, and just gently putting your fingers on there. It does take some practice, but his pulses are quite strong. The real trick is actually finding a time when the infant is quiet. If the infant's not quiet, it's going to be really difficult to find a good pulse. Okay. I'm examining the feet. Again, we looked at the color of the feet, and we looked at these lines as a sign of gestational age. You also want to make sure there's no positional deformity, that it's not everted or inverted, as you might see with a club foot, and then it's got good flexibility in both directions, which Riley certainly does. Good. And then I'm going to check his hips. There's two different maneuvers to examine for developmental dislocation of the hip. And essentially, if you imagine the hip femoral head normally sits in the acetabulum or joint, and if it's abnormal, it's going to slide either along the joint capsule or even behind the joint. What you're essentially doing is looking to see if you can feel or hear the sound of the joint, the femoral head popping back into the joint. So if you imagine that the hip femoral head is posterior to the hip joint, and you're kind of flexing and pushing it forward, and you might feel a clunk. You might very often hear a click, which is not abnormal. That's just a sign of ligamentous laxity and movement of ligaments across the joint. So there are two different approaches. Some people do both at the same time, both hips that is, and some people do one at a time. So it's good to have the infant relax like he is now. You're just gently going to flex, and then I'm pushing. I have a hand on either side of the femoral shaft here. I'm going to flex or abduct the hip, and then I'm pushing up here to feel if I feel the hip come out of joint, and it does not. So again, just like that. The same thing on this side. Just I'm going to abduct the hip, and then I'm pushing up and feel if it's... So that's called the Ortolani maneuver, and the mnemonic I always use is Ortolani is for out. You're moving the hips out, and that's the Ortolani maneuver. The Barlow maneuver is very similar, but the idea behind there basically is, what if the hip, here's the acetabulum, and the head is kind of sitting here. You might not feel much of a clunk as you're moving it, but if you push it down out first and then flex, you might. So very similar. Again, you're just kind of imagine you're pushing down so that if it's on the edge, you're pushing it out of joint, flexing, and then doing essentially the Ortolani maneuver again. and push down and out. And again, no sign of ligamentous laxity. His hips are stable. So good. And notice also you can assess his tone. Look how nicely, if I do that, it just kind of flexes back up. That's a sign of good tone. This is not an infant who has low tone. Right. So examining the genitalia, for a male, you have a couple of things you want to look at. Number one, you want to look to see if there is, if the meatus of the urethra is in the midline, or if you have what's called a hypospadias, which is where you might see the opening somewhere here along the shaft, or an epispadias where it's above the area. It's sometimes hard to see the actual opening in an uncircumcised infant, but here I can see the opening pretty well. I don't know if you can see that right in the midline. And then you want to check and see. Okay. And then you want to check and see if the testes are descended on both sides. Look for any hydrocele, which is extra fluid. And then for both infants, you're going to examine the anus as well, just lifting up. And you can see that normal star-shaped pattern that indicates the normal muscle around the anus and a patent anus. But in terms of a summary, basically, you see all the steps. And again, as I mentioned, the real key here is you have to kind of use the steps that work for you. You may not get a patient who is cooperative all the time, so you do the parts that you can do when you can do them. And you have to be patient and wait for the infant to kind of be calm and quiet to do certain portions of the exam, for example, the cardiac exam or the femoral pulses and those kinds of things. Those really require a quiet infant, which he certainly is now.